Good morning and good afternoon. My name is Tam Nickerson, and I am a proud member of the 22 Delta Research and Educational Foundation Research Working Group. I would like to welcome you to our National Research Symposium, which is our culminating event for 2023-2024 program year. We have some amazing speakers lined up for you all today who hold a wealth of knowledge in the health equity space, so we are certainly in for an impactful event. Please note, for your viewing pleasure, this is a webinar format, so all attendees are muted and cameras are off. You may use the Q&A feature at the bottom of your screen for any questions, comments, or concerns. Today's symposium will be interactive and engaging, so we ask that you remain online until the end of the program so that you get the most benefit from today's event. Before we proceed with our presentations and workbench demonstration, we are happy to share the following disclosures. Specifically, we can provide 2 hours of continuing medical education units for this session. Disclosures. The Delta Research Educational Foundation, Riverside University Health System Medical Center, CME, faculty, planners, speakers, CME committee, and others in control of the content, either individually or as a group, have no relevant financial relationships with ineligible companies. There is no commercial support for this CME activity. An ineligible company is any entity whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Please watch this short video introduction to the National Institute of Health All of Us initiative. Now I would like to introduce Ms. Renee Harper. Ms. Renee L. Harper of Boston, Massachusetts, is the DREF Board President. Professionally, Ms. Harper is the Chief Financial Officer and partner at Education Resource Strategies, ERS, an educational consulting organization. Prior to joining ERS, she was the Assistant Vice President and Controller at Liberty Mutual Insurance, a Diamond Life member of Delta Sigma Theta Sorority Incorporated. Ms. Harper has been a member since 1989 and is currently a member of the Boston Alumni Chapter. She has performed numerous roles in Delta on the local, regional, and national levels, including Chapter President, National Finance Chair, and Leadership Delta Co-Chair. Ms. Harper earned her bachelor's degree from the University of Rochester, a master's in business administration from Boston University, and a master's of science in accounting from Bentley University. She has earned numerous awards for her leadership and financial acumen, including the Chairman of the Board Award at Liberty Mutual, Finance Excellence Award at Digital Equipment, and Boston YMCA Achievers Award. In the Boston metropolitan area, she serves on numerous boards, including Vice Chair of the Visiting Nurses Association, Chair of the Church of Council for Greater Framingham Community Church, Vice Chair of the Human Relations Commissions for the City of Framingham, and Chair of Internal Audit and Scholarships for the Boston branch of the NAACP. Her favorite mottos are, "Service is the rent we pay for living. And if I can help someone along the way, then my living is not in vain." As chair of the National Research Symposium, it is my honor and privilege to introduce our working group community to the president of the Delta Research and Education Foundation, Ms. Renee Harper.
Thank you so very much, Ms. Nickerson, for that wonderful, wonderful, wonderful introduction. I am here to bring you greetings and to welcome you to this phenomenal symposium that we're having this afternoon. On behalf of the Board of Directors, I welcome you to the event, which is the accumulating event of the All of Us NIH activities for this year. Its focus on healthcare disparities closely aligns with the work that we're also doing in DREF from our sister scholars, where they're undertaking related research around healthcare access, equity, and utilization. DREF recognizes that healthcare is the most critical social issue that we are facing and the impact it has on our respective communities. To that end, this symposium helps to set the stage for the ongoing research of the DREF 22 and their commitment to healthcare equity. I'm excited to hear from this esteemed panel of experts and speakers that we have this afternoon. So you're in for a real treat. I'm going to sit back and listen and learn as well. So I invite you to come and join us and enjoy the symposium. And thank you for joining us this afternoon. Have a great day and enjoy the program.
Great. Thank you so much, Ms. Harper, for that warm welcome. Now I would like to introduce Dr. Kareem Watson. Dr. Watson is the Chief Engagement Officer of the All of Us Research Program at the National Institutes of Health. In this role, he leads the Division of Engagement and Outreach, overseeing the program's efforts to foster relationships with participants, community partners, researchers, and providers across the United States. Dr. Watson holds a doctorate in health science, global health, a Master of Science in Basic Medical Research, and a Master's in Public Health, Community Health Sciences. He has served as the principal investigator on multiple projects, including those funded by the National Cancer Institute, the National Institute on Minority Health and Health Disparities, and the All of Us Research Program. Please welcome Dr. Watson.
Good afternoon and good morning. Can you all hear me okay?
Yes.
Thank you for having me here. And thank you to DREF Board President Harper for this invitation. And thank you to Cheryl Thomas and the rest of the DREF team members for the invite today. It's truly an honor and a pleasure to be here to thank you all and to congratulate you all, the DREF 22, on the amazing progress that you all have made. We're excited in the All of Us Research Program here to be one of the world's largest and most diverse genomic and precision medicine initiatives in the country. And the fact that we have done something unprecedented when it comes to precision medicine. People often say, what is this whole concept of precision medicine? And in a nutshell and in layperson's term, precision medicine is truly moving away from that one size fits all approach to research and healthcare, so we can truly understand our family histories, our lived experience, diet, lifestyle, environment, and all these other things, how they come into play into how they inform our health. And for us to better understand how to develop treatments, interventions, and even preventions, we must make sure that researchers have access to this data. And collaborating with DREF, the Delta Research Education Foundation, and the DREF 22 is a step in the right direction. And it's also making sure that we hold true to your mantra today of making sure that scientists of color, African-American women, have a seat at the table in driving this research forward. I'm so thankful to you all for being here. Thank you all for being a part of the All of Us Research Program. And thank you to DREF for being a partner with us in ensuring that communities and populations who have been historically underrepresented in biomedical research not only have a seat at the table, but have a seat in owning the room, determining what's on the menu, determining how we make sure that the food is distributed to people who normally don't get the resources that they need. So thank you, DREF. Thank you, all of you all at the DREF 22. I look forward to this day hearing more about how we can continue to advance science together. Thank you all.
The National Health Initiative, conducted by the Delta Research and Educational Foundation in collaboration with Delta Sigma Theta Sorority Incorporated and the National Council of Negro Women, is entitled Research Matters: Creating Possibilities to Achieve Health and Wellness for All of Us. The objectives are to engage, educate, and ultimately enroll African Americans in the National Institutes of Health All of Us 1 in a Million campaign, a national database primarily comprised of diverse and traditionally underrepresented populations. The mission of the All of Us Research Program is simple. It is to speed up health research and medical breakthroughs by asking 1 million people to lead the way to provide the types of information that can help create individualized prevention, treatment, and care for all of us. African Americans continue to have some of the highest incidence, prevalence, and mortality rates from chronic diseases such as cardiovascular disease, diabetes, obesity, hypertension, mental health, and HIV/AIDS. Yet we comprise only 5% of clinical trials participants in America. Our focus and objective is to create awareness about how research matters in closing the health disparities gap. For more information, please visit www.joinallofus.org/DREF.
Good afternoon, everyone. We have 4 gift card giveaways scheduled throughout the National Symposium. To win the first 3 gift cards, be the first person to provide the correct answer to a question posed in the chat. Be sure to stay online for the entire duration of the symposium, as there will be a final chance to win a gift card at the end. So let's get started. It in the chat. Who is credited with saying, if they don't give you a seat at the table, bring a folding chair? Wonderful. We have a winner. It looks like Tina Fernandez. You're the winner of the first gift card. Thank you all for participating.
Thank you so much, Dr. Papadis. I would be remiss if I did not acknowledge our DREF leadership team, many of whom are with us today. The leadership team is composed of 2 components, DREF's core team, as well as DREF's Research Matters for All of Us team. The DREF All of Us Research Core team is led by Dr. Mandy Hill, Researcher Specialist. Dr. Mandy Hill brings 22 years of experience as a researcher and a public health practitioner to the DREF team. She is the DREF Researcher Specialist and leads the 22 DREF Research Working Group to advance diversity, equity, and inclusion in the NIH All of Us Researcher Workbench. Dr. Hill believes it's imperative that narratives shaped by the data provided by communities across the nation as participants in the NIH All of Us program be informed by perceptions and lived experiences of Black researchers. The members of the 22 DREF Research Working Group join her in taking the same just stand. To learn more about NIH and the All of Us program, please see the link in the chat. Please welcome Dr. Mandy Hill.
Thank you, Ms. Tam Nickerson, for your culminating event of the 2023-2024 grant year. It is my privilege and pleasure to acknowledge Dr. Paulette C. Walker, the 25th National President of Delta Sigma Theta Sorority, Incorporated, for being here with us, and all of you for being here with us at our 2nd annual National Research Symposium. As we did in June of 2023, the 22 DREF Research Working Group has purposefully chosen to reinforce our attention on advancing health equity within the Black community. Black people in the U.S. continue to face more health inequities than every other racial and ethnic group. This is, in part, a consequence of how our society places hierarchical value on human life using constructs like race. As such, the impact of social, structural, environmental, and political determinants of health on our lived experience remains a heavy burden. The collective health sequelae to Black people in the U.S. persists today. But the story does not end there. Today, there is hope for a different realized future. We have the opportunity to tell a new and more informed story through rich data sources like the NIH All of Us Research Program. Through this symposium, you all will learn more about why our nation's state of population health requires our attention, and how becoming a registered and active user of the NIH All of Us Researcher Workbench can be a pivotal resource to our unified plight to promote better population health within the Black community. The DREF Research Matters for All of Us initiative is a community engagement grantee of the NIH All of Us Research Program. And our objectives are to engage Black and African American communities in 3 specific ways. We want to create awareness about research within the Black and African American community. We also want to share information about the current state of health within this community here in the US and encourage health and wellness through education, like we're doing today through this symposium focused on health equity. And lastly, importantly, we want to encourage members of the Black and African American community to enroll as participants of the NIH All of Us Research Program. These objectives are directly linked to the overall aims of the NIH All of Us Research Program, which are to improve healthcare outcomes and to decrease health inequities. Data at the level of each person will help researchers and clinicians to design treatments and healthcare pathways that will increase access to health equity among all people. And the program focuses on precision medicine to put forth this agenda. So the program offers benefits to people and patients, healthcare providers, and biomedical researchers. We focus on the researchers here. So registering with the Researcher Workbench can reduce the time spent on developing new tools. It can reduce the cost and time associated with participant recruitment and offer access to diverse data that may be powered to answer your research questions. Here is a snapshot of the diversity of data that exists within the Workbench. I now have the esteemed pleasure of introducing you all to the 22 DREF Research Working Group. This working group is comprised of 22 national Black and African American female researchers who are also members of the illustrious Delta Sigma Theta Sorority Incorporated. Together, we are providing education through lunch and learn sessions and symposiums like this one. We're also employing outreach opportunities to connect with Black and African American researchers nationwide to engage them as registered users of the NIH All of Us Researcher Workbench. During the 2023-2024 program year, through our education pillar, we have implemented 4 education lunch and learns covering diverse health topics that included heart health, HIV, and we addressed this on World AIDS Day, mental health by focusing on behavioral interventions, and finally, suicide in the Black community. We also have a pillar that is dedicated to the Researcher Workbench activity, and through this pillar, we engaged over 30 researchers as potential users of the Workbench. Of those 30, we can confirm that 8 or more are now current registered users of the Workbench. We engaged 25 colleges and universities to encourage them to establish a DURA, which is a data use research agreement, and is a relationship between the NIH and that particular institution. Of the 25, approximately 70% were HBCUs, and we can confirm that 4 DURAs were established through that effort. 3 members of our working group were trained through the Baylor College of Medicine Train the Trainer program. One of our members was selected as a cohort member of the NIH All of Us Biomedical Research Faculty Summit. And we established 4 new notebooks in the Workbench that address sickle cell disease, cancer, breast cancer, and health equity. Of those notebooks, 2 abstracts are under review for presentation at national conferences, and you will hear from one of those first authors, Dr. Lakeisha Cousin, later on in this symposium. Through our outreach and engagement pillar, we were able to establish several collaborators this year through table hosting and presentations through an in-person and virtual format. On the next slide, you will see those logos displayed here, and these collaborations have helped us to increase awareness and scale up impact toward our shared goals of supporting inclusive and visionary research. Again, we thank each of you for being here today, and you will now hear from our Level 1 Leader of Education, Ms. Kalisha Mays.
Thank you, Dr. Hill. Hello, everyone. My name is Kalisha Mays, and I'm the Chair of Educational Development for the DREF 22 Research Working Group. I have the distinct pleasure of introducing our fireside moderator, Dr. Heather Rice, who is also a member of the 22 DREF Working Group, and our notable Delta, Karen Walker Johnson. Our fireside moderator is Dr. Heather Rice. Dr. Rice is an associate professor and researcher from Cleveland State University College of Health, School of Nursing. She also holds a board certification as a pediatric nurse practitioner, specializing in child and adolescent psychiatry. Dr. Rice has established a comprehensive program of research that centers around maternal and infant health, mental health, birth equity, chronic stress, and the prevention of maternal and infant mortality within the African American community. Beyond her academic and research pursuits, she passionately advocates for reproductive justice, women's and children's health, trauma prevention, and mental wellness. Dr. Heather Rice is committed to engaging in community-centered research approaches, working in partnership with the community organizations Birthing Beautiful Communities and Village Healing Center. Our fireside contributor and notable member of Delta Sigma Theta Sorority Incorporated is Mrs. Karen Walker Johnson. Mrs. Walker Johnson is an independent board director for public and private companies. She also serves as an advisor to private equity-backed early and mid-stage healthcare tech companies. She currently serves as executive chair and interim COO for Cleaver Care Health Plan. She recently served as interim CEO for the March of Dimes, where she led the organization in the fight for health of all moms and babies. With more than 35 years of experience in health care industry, Mrs. Walker Johnson has a deep operational expertise in highly regulated insurance lines of business, product development, direct-to-consumer growth, compliance, and organizational transformation. Recognized for her strategic and business acumen, her passion is leadership development and positively impacting and improving the health status of vulnerable populations while advancing health equity. She earned her Bachelor's of Science degree in nursing from the University of Michigan and a Juris Doctorate from Michigan State College of Law. She also holds an executive certificate from the Wharton School of Business. Please join me in welcoming Ms. Karen Walker Johnson and Dr. Heather Rice.
Thank you for that introduction. It's truly an honor and a privilege to hold this fireside chat with you today, Ms. Karen Walker Johnson. Considering your extensive and impressive experience in the health equity space, how do you define health equity, and why is it a critical issue in today's healthcare landscape?
Well, good afternoon, and thank you so much, Dr. Rice. It is a pleasure and a great opportunity to be here and to participate in this symposium today. This is a topic that is near and dear to me, and so I really appreciate having the opportunity to spend some time here with you today. You know, when you ask about my definition of health equity, if you look in the literature, if you talk to people, if you turn on the television, you will hear many different definitions on how people describe health equity. But for me, I'm pretty consistent with the Centers for Disease Control in that it really is the ability to attain the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of their race, their ethnicity, their sexual orientation, their gender. It really is just that ability. And when you think about how can we do that, there are a lot of different things that impact that. And it is such a critical issue in today's health, as we already heard it at the very beginning here with the video is that at the end of the day, our health equity is really impacted by implicit as well as explicit bias. Implicit bias, the way I would describe it is it's really when people have this unconscious attitude, unconscious reactions and stereotypes and categories that impact people's behavior and their understanding of others. What's the root cause of that? Pretty simply, it's driven by inequality, discrimination, and a long-standing, deeply rooted racism in our U.S. healthcare system. I mean, we could look back and have lots and lots of examples of that, but at the end of the day, that's really at the root of it. Those disparities in healthcare equity, they often prevent people from being able to receive or even seek healthcare services. And with that, that in itself can negatively impact their quality of life. What we know, though, is that these disparities are preventable. You know, I think about statistics, and when you think about, you know, who's most disproportionately impacted by health inequity and by discrimination in the health space. You think about those who are uninsured or underinsured, people who have lack of access to basic things like a primary care physician. We take that for granted, but many people don't have that access. When you look at African Americans, we have a shorter life expectancy than others, sometimes in the neighborhood of 5 to 8%. 5 to 8 years. We're less likely to get, as you know, in your field, to have access to behavioral health services. And then we can't even begin to start to talk about the crisis we have in the maternity and infant space. Our morbidity for women and children is 3 times that of our white counterparts. So when I think about that, and I think about what happened during COVID-19, we represent 12% or so of the population, yet disproportionately, the numbers are, they kind of vary, but somewhere in the neighborhood of 14-15% of the people who died during that period of time look like you and me. And so when I think about health equity, again, it's how do we attain that highest level of health for everybody, regardless of who they are and where they come from. One last thing I'd like to say about that is that, you know, when I think about what are some of the ways that we can think about how we can positively impact it. You know, I like people to think about your neighborhoods and your communities and your schools. You know, if the quality of our neighborhoods, if the quality of our schools are not there to support our children and our communities, that will negatively impact their health. And so it's really important that we have access to clean and safe and resource-rich neighborhoods and schools, because that in itself is going to help us address health inequity.
Absolutely. You've talked a little bit about community intervention. Can you also talk about some strategies that maybe healthcare providers can employ to improve communication and trust with diverse populations?
You know, I think personally, I've worked in healthcare all my career, and I think that healthcare providers, and there's a wide spectrum of healthcare providers, but I think we have, as healthcare providers, the best opportunity to positively impact and to help our communities to be well. And that starts with what is called culturally competent care. And so, you know, I remember when I first heard that term years and years ago, I really wanted to understand, you know, just what does that mean? But one of the things that we know is, and I'll talk a little bit more about that, is that we know that when you have culturally competent care, when your providers are culturally competent, and they're supporting their patients with that racially concordant care, that you get better outcomes. Providers, they recognize and they acknowledge their patients' cultural identity. They are able to find ways to empower their patients and letting them know that they trust their judgment. Just something as basic as that, when your patient is sitting in front of you, that you trust their judgment, that you believe in them, that your patients actually know what's best for them. And often that's not people's experience when they're sitting with a provider. But when that provider looks like them, when that provider has shared experiences as them, you begin to develop a trust just in that interaction alone. Also, when you have cultural competency, you know, the providers are able to practice with humility. They acknowledge that though we may look like each other, we may have, quite honestly, a different economic status simply because I'm professional and perhaps you are someone who has more challenges from an economic perspective. And so providers who are culturally competent and aware of that and acknowledge that, they begin to establish trust with their patients. The other thing I would say is that it's really important that providers who are really working in communities of color, working with African Americans, that they are educating themselves on what are some of the unique nuances that illness and how illness presents in people of color. You know, we saw earlier that diabetes, hypertension are things that we are more at risk for. And so providers can't ignore that. They can't express disbelief, if you will, when their patients of color speak up. They can't minimize the way that they may have been treated, because all of those things will contribute to more of a lack of distrust. And it's really important for a patient to have trust with their provider. What can providers do? They can ask questions to better understand their patients. They can help their patients. And whoever comes in to accompany them, often, particularly when you have older patients, they come in, they may bring their son or their daughter or their niece or grandchild with them. It's really important for you as a provider to look people in the eye, to speak to them with respect, to answer their questions, to encourage them to ask questions, right? And I think that going back to that bias I talked about is that when we as providers work to recognize and work to eliminate that bias, that unconscious bias, that in itself will help us be able to advance the health that we really want to provide to our patients. And then finally, I would say that it's really important to respond to the concerns of your patients, and do that in a respectful way, so that they want to come back to see you, so that they'll follow whatever your plan of care is, right? We can standardize some of that care. Often, there are evidence-based standards of care and practice that we know work better in our communities. And so I encourage the providers I work with, in fact, in many cases, we require of them that they utilize some of those so that we don't have, just kind of willy-nilly, if you will, practices with our patients. We want all of our patients to be treated fairly. We want all of our patients to get the very best in terms of what we provide them. And it's important to do that from a lens of knowing that we can all have unconscious bias, but also recognizing that the more culturally competent we can be, we will get better outcomes with our patients.
Absolutely. Thank you for providing those examples. Do you see any future challenges or roadblocks that professionals who are working to address and reduce health disparities may face?
Unfortunately, I do. And I guess I would start with what's been happening with affirmative action. And I want to put the context of why that's so important. So as you see, people and institutions really working to dismantle affirmative action, what will that mean when we think about our healthcare providers? What that means in reality is we will have fewer opportunities for physicians, for people who want to go to medical school, people who want to go to nursing school, people who want to do research. When you think about social workers, et cetera, if we can't and have more difficulty getting into places to be educated, that means then on the outside, when they work through that funnel, if you will, we will have less providers who look like us. And then I get back to what I said earlier, which is where we know we have the best outcomes is when a provider sitting in front of a patient looks like them, where they have their shared experiences. So if you don't support affirmative actions to bring more people of color into medical school, then you will have less doctors who look like them. And therefore, you will have less doctors who are able to provide culturally competent care. And the result will be that we will continue to perpetuate more inequity in the way healthcare is delivered. That's one of the big things that I see as a problem. Another is reimbursement methodologies. Reimbursement is changing. Historically, people were paid on what's called fee for service. So you provide a service, you would get a fee. But what has happened is that there is much more emphasis now on what is called value-based contracting and value-based care and reimbursement. And what that means is that reimbursement is literally tied to the outcomes that one gets. The federal government is requiring this now. You see it on the state level, you see it on the federal level, you see it in payers. They are insisting that providers are paid that way. Well, how is that a problem? Unfortunately, many of the providers of color are practicing in communities and neighborhoods where they don't have access to understanding what is different about practicing under value-based care. They don't have the access, if you will, to payers who are doing educational seminars around how to make sure that a provider can be reimbursed well. Those are the types of things that will drive providers in underserved communities out. They won't be able to sustain their practices because they aren't getting enough reimbursement. So that's another one. And then finally, I would say that another is and it gets back to the research. When we don't have participants in our research studies who look like you and I, then we don't get data on the other end that is useful and then is needed in order to be able to positively impact those illnesses and those diseases that impact us most. And so it's really important that we not have barriers that prevent people of color from participating in those research studies, and that we have the ability for our researchers who look like us to be able to have access to those types of studies.
Absolutely. So we've reached our last question, and I'm wondering, what would be your advice for healthcare professionals and researchers who are interested in integrating an equity lens into their work?
There's so many things. We don't have enough time. But let me give you some of the things that I think about. One is just being intentional. Being intentional, being an advocate. And what I mean by being an advocate, this is going to sound really simplistic, but we all need to vote. And when you vote, when you write your legislators, when you participate in Days on the Hill, et cetera, that's your opportunity to talk about what's important in the healthcare space. That's your opportunity to advocate on behalf of our communities. That's your opportunity to talk about why it's important to make sure that medical schools and nursing schools, et cetera, are admitting students of color. So that's one of the things that we can do. We can also participate more so in our communities. I love the things that Delta does and other organizations do in the community to educate the communities about the importance of health and the importance of them getting and taking care of their health. You can educate yourself. You can go to conferences. You can pursue leadership roles. I cannot emphasize enough how important it is for us to step up into leadership roles, to sit on boards. That's why I do that. Is so by sitting on a board, I have a voice in the room. I get to be that person who says, we're only looking at, quite honestly, the white patients. What about the patients of color? So those are the types of things providers can do, is get yourself in the room, get yourself on boards, use data. Always use data to foster improvement, continuing to participate in clinical trials and encouraging your patients to participate in clinical trials. We can measure equity. That's really important. There are organizations that do that. The National NCQA, the National Committee for Quality Assurance, state and federal agencies now, they are actually measuring health equity. And so let's make sure that we are part of that conversation and that we're providing data and hiring a diverse workforce. That is so important. So if you're a physician, make sure that your staff is reflective of the people that you're taking care of. Not only will that inure trust in your patients who come in the office, but it also gives people like us an opportunity for them to continue to improve their lives. And so I would really encourage you to do that. And then finally, let's continue to work on dismantling racism. You know, implicit bias training is something that we can participate in and that we can perpetuate and we can advocate for. Where there are anti-racism tools in healthcare, utilize them as much as you can. So, you know, probably one last thing, everybody talks about AI now, you know, artificial intelligence. That's an area, quite honestly, that concerns me a bit. And let me tell you why. It is the fact that the data that is being utilized in order to drive AI, most of that data does not have people like you and me in it. And the people who are sitting around the table who are developing the algorithms for AI, often they don't look like you and I. So if you think about it, what's going to come out on that other end that's going to be used to do things that impact our health, if we're not there, if we don't have people that are participating in that process, we don't have data sets that look and have data that reflects people that look like you and I, then that to me is going to be problematic. So that I think is another area where as a provider, you can get involved.
Well, thank you again, Ms. Karen Walker Johnson, for taking the time to speak with us today for our fireside chat. We truly value and appreciate your time and expertise in the health equity space.
Thank you so much.
Good afternoon, everyone. Thank you again for an amazing presentation and amazing discussion. At this time, we will have another moment for any additional questions from the fireside chat. We might have time for one more. And if not, we will proceed to honor the time of the day. Okay, I don't see any questions. So we'll proceed with the next slide. Forgive me, one question did just pop up, and if we have time to address it, Ms. Walker, how do you see this issue tying into the Black wealth gap?
There's so many ways I could address that question. I'm just thinking for a moment. Well, let's talk about, so if we aren't healthy, if our lifespan is shorter than others, then we have less opportunity in terms of our earning potential. And as I think about, there are so many people who look like you and I who are doing phenomenal things. But as we do those things, are we thinking about generational wealth? Are we thinking about ways to make it better for those who are coming behind us? I know when I was growing up as a kid, the thing my parents and my grandparents said to me is, Karen, we want life to be better for you than it was for us. And sometimes I wonder if that's still the mantra, quite candidly. You know, so in terms of how it can affect our wealth ongoing, I think being healthy, being able to have your highest earning potential, saving, teaching your children the importance of their health and the importance of saving, et cetera. Those are the things that will help us, I believe, in our building wealth. But again, we need to think about it as generational wealth, not just what do I have right now, but what am I doing to help my children, my grandchildren, my great-grandchildren, so that they will have greater opportunities in terms of whether it's their education, whether they pursue some type of skill, whether whatever it is they want to do, but them having the opportunity to do so and to do that because they're healthy.
Thank you so much for that. And we do have a few other questions, but again, we want to make sure that we honor our schedule. So as time presents, we might be able to address some of those additional questions. But again, Ms. Johnson, thank you so much for your time today and facilitating this amazing discussion. And I'll pass it along to Dr. Papadis, who's going to Well, before I do that, we do have a fireside chat evaluation. This information helps us kind of guide our next conversations and our next discussions. So if you wouldn't mind taking 2 seconds to fill out this evaluation, we would be very, very grateful. And as we're doing that, we'll prepare for our next speaker, our next giveaway, Dr. Papadis.
Great. Thank you, Dr. Rice and Dr. Wright and Mrs. Walker Johnson for the detailed insight into the health equity, excuse me, and how it is impacting our society. And so now, okay, so now it's time for the second gift card giveaway. Again, be the first person to provide the correct answer to a question in the chat to win. Get ready. Okay, name one of the 3 objectives of the DREF Research Matters for All of Us initiative. Great. Looks like we have a winner. We'll give credit to Alexandra Winston for her answer on health equity. The top 3 or main objectives for the DREF Research Matters for All of Us initiative: 1, create awareness and encourage enrollment, encourage health and wellness, and educate the Black and African American community. So congratulations.
Thank you, Dr. Papadis. We now like to continue our symposium by sharing with you some highlights from the research efforts of the 22 Research Working Group. However, before we do that, I'd like to acknowledge another notable Delta in our audience, which is our past Far West Regional Director, Sandra Phillips Johnson. Thank you for joining. At this time, let me introduce Dr. Lakeisha Cousin. She is an assistant professor at the University of Florida College of Nursing. Next month, she will begin her tenure as the Assistant Director of Community Outreach and Engagement at UF Health Cancer Center. Clinically trained as an adult primary care nurse practitioner, she is leading experts in eliminating cardio-oncology disparities. Her work focuses on developing biobehavioral interventions to reduce chronic stress and cardiometabolic risk among Black breast cancer survivors. Dr. Cousin's funded research and service have earned her prestigious awards, including the National Cancer Institute's Early Investigator Advancement Program Scholar Award in 2024 and the 2023 University of Florida Health Cancer Center's Rising Star Award. Dr. Cousins continues to push the boundaries of nursing science, emphasizing community outreach and engagement to improve health outcomes in underserved communities. Please join me in welcoming Dr. Lakeisha Cousin.
Thank you so much for that lovely introduction. And so I am so pleased to present on behalf of the work done by our DREF 22 working group. And so we developed a research question focused on social demographic disparities associated with stress, cardiovascular disease, and cancer outcomes. And this work is a part of our amazing DREF 22 working group's All of Us research project. Next slide. So the primary purpose of our research is to examine the association between race, ethnicity, perceived stress, social demographic factors, and health outcomes such as cardiovascular disease and cancer. And so this research is very important for us for several reasons. First, it aims to address the racial disparities that are experienced in cardiovascular disease and cancer. Although these disparities are well documented, racial and ethnic minorities are still often experiencing higher incidence and worse outcomes for these diseases. And so by focusing on these disparities, we can identify specific areas where interventions are needed the most. And that's where my joy comes in, developing these culturally relevant interventions. And so secondly, our study seeks to understand the role of stress and social influencers in health disparities. And so when we think of chronic stress, that a lot of times for our Black folks are driven by social determinants of health. And we think of these social determinants like economic instability, access to healthcare. We also have experiences of discrimination. All of these things play a crucial role in exacerbating these health inequities. So by exploring how these factors contribute to health outcomes, we can better understand the pathways through which disparities arise and also persist. So our research question is focused on, is there a significant association between race, ethnicity, perceived stress, and social demographics and these health outcomes I just talked about? Next slide. And so to address the research question, we employed a robust scientific approach, and I'll speak in layman's terms for everyone in the audience. So the statistical test that we used was logistic regression analysis, and this helps to evaluate the impact of various social demographic factors and perceived stress on health outcomes. And so you may wonder, okay, what is all about the All of Us workbench? Well, we use data collection using electronic health surveys and also electronic health records from hospital records. Next slide. So let's briefly talk about our results. So for our participant demographics, in our study, we analyzed data with a substantial cohort of 55,505 participants. And so our mean age for these participants, on average, were about 52 years old. And so this provides a mature population for examining long-term health outcomes. And we look at our racial composition. Now, the majority of the participants were white, but we want to acknowledge that Black or African American individuals made up about 8.3% of the sample. And when we think about an ethnicity, so whether they're Hispanic or non-Hispanic, about 9% identified as Hispanic, while the remaining 91% were non-Hispanic. And when we look at education, most participants had a college or an advanced degree. And so what this means is that they really had a lot of high educational attainment within our study group. This is a crucial factor, as education levels often correlate with health outcomes and access to healthcare. Now, in terms of income, a significant portion of our participants earned over $100,000 annually. And so this higher income bracket may influence their access to resources and overall health status. And when finally looking at perceived stress, the majority of our patients experience mostly low to moderate levels of stress. And so this variable is particularly important as stress can significantly impact both cardiovascular and cancer outcomes. And so just looking at this demographic detail, this provides the essential context for interpreting some of the next study findings I'll just talk about regarding disparities. Next slide. So first up, cardiovascular disease. So in our statistical analysis, we use a term called adjusted odds ratio. And so this helps us to highlight the associations more clearly. So let me explain real quickly. So you think about odds ratio, it compares the odds of an outcome occurring in one group versus the odds of it occurring in another group. So when you see that number that's greater than 1, that means there's a higher risk, and vice versa. If it's lower than 1, that's a lesser risk. So let's take a look at our findings. So for Black or African Americans, the odds ratio was 1.18. This lets us know that Black or African American individuals have an 18% higher odds of developing cardiovascular disease compared to white individuals in our sample. When you look at stress, there is an odds ratio of 1.27. That lets us know that the higher levels of stress are 27% higher when you have cardiovascular disease. And more importantly, when you have a lower income less than $25,000 a year, it's even more pronounced. There's a 33 higher odds of having cardiovascular disease with low income. But I wanted to point out with a college degree, While having higher education is generally protective against many health outcomes, this might suggest that complexities like job stress or other related factors can have an impact. As you can see, there's 11% higher chance with cardiovascular disease. All right, next slide. Let's move on to our cancer outcomes. So our study identified two main factors associated with the increase of cancer, and it was expected: older age and moderate stress levels. And so when you take a look at the age, now that we know, all of us know what odds ratios are, when we take a look at the adjusted odds ratio for age, the odds of developing cancer increases by 6%. So it's significant and indicates that older individuals in our sample have a higher risk of cancer. Now, when it relates to moderate stress, there is a 12% higher risk of developing cancer compared to those who have a low stress level. And so this is also statistically significant, and it highlights the impact of stress on cancer risk. Next slide. So what are some of the key takeaways that I would love for you all to take away from our brief presentation from our working group? There are several components. So our data show that certain racial and socioeconomic groups are disproportionately affected by cardiovascular disease and cancer. And so this indicates a further investigation by all of our wonderful researchers here into the underlying cause of these disparities. For example, with my work with breast cancer survivors, Black women have a 41% higher mortality rate, more likely to die than our white individuals. And a lot of times, some of these factors that we're examining, like stress, can make a huge impact. We also found a strong association between higher levels of perceived stress and worse cardiovascular disease outcomes. So this all suggests that stress management can be a vital component of interventions aimed at improving cardiovascular health. And we also found some interesting mixed results for cancer outcomes, and this suggests the complex underlying factors that come along with cancer survivorship. For overall, our findings highlight the need for culturally relevant targeted interventions to address health disparities influenced by race, social determinants of health, and stress. Next slide. So now that we've done all of our data analysis, we can't just let it sit. We need to disseminate. And so the DREF 22 work group, we have plans to submit our analysis to the 2024 American Heart Association Scientific Session in November in Chicago. And for me, the timing is perfect because I was recently invited to be a moderator over a symposium titled Cardio-Oncology in the World, the Real World, Disparities in Health Equity and Cardiovascular Cancer Outcomes. So I took that as a perfect opportunity to be able to represent DREF 22 and the NIH All of Us research program. So thank you all for your time and attention. Next slide, I'm done.
Thank you, Dr. Cousin, for that amazing presentation on behalf of the 22 Working Group. Now it's time for another gift card giveaway. Again, be the first person to answer correctly a question based on Dr. Cousin's Workbench research presentation in the chat to win a gift card. Based on Dr. Cousin's research, name one of the risk factors for cardiovascular disease. Wonderful. Looks like we have a winner, Yvonne Collins. Congratulations. And just so you all know, older age, Black race, lower education, lower income, as well as higher perceived stress were some of the research risk factors mentioned. Thank you.
Hi, thank you, Dr. Papadis. My name is Dr. Denise Kimbrough, and I'm a proud member of the 22 DREF Research Working Group. I now have the pleasure of introducing our workbench presenter, Dr. Angelica Mindy. Dr. Mindy is an assistant professor of epidemiology in the Department of Environmental and Public Health Sciences at the University of Cincinnati College of Medicine. His research is on the environmental exposures associated with adverse respiratory outcomes. He investigates the potential role of DNA methylation in predisposing to genetic susceptibility for respiratory disease. He is also the concentration director for the Masters in Environmental Public Health program and the associate director of the Molecular Epidemiology in Children's Environmental Health, P32 training program at the University of Cincinnati. Please join me in welcoming Dr. Mindy as he discusses leveraging the NIH All of Us research program to reduce health disparities in genomics research.
Thank you, Dr. Kimbrough, for the introduction. Please allow me to share my screen. Can you all see my screen?
Yes.
Okay. So thank you for the introduction and the opportunity to give this presentation. So in my disclosures, I am a research ambassador for the NIH All of Us Research Program. And my role is to advocate for the program, to raise awareness about the program, and to motivate other investigators to do research in All of Us. So if you are involved in biomedical research, you know that we are at an exciting time. This is the era of omics, right? And omics, om meaning whole. And then omics, these are fields in biology ending with omics. And then the goal of this field is to study the totality of a certain type of biomolecule or biological process. For example, if you look at our cells, we have the genetic material that defines who we are. Now, the central dogma of biology is that we have DNA, which is transcribed into mRNA, which is translated into proteins, and then the proteins form the metabolites. Now, the study of all the genes is genomics. Before, a lot of people used to spend a lot of time studying just a few genes. That was the era of genetics. Now we can study all the genes, genomics, right? The study of all the mRNA transcribed from DNA, that's transcriptomics. The study of all the proteins translated from mRNA, that's proteomics. And then the study of all the metabolites formed from proteins, that's metabolomics. There's other omics, such as, for example, epigenomics. So this is a study of gene expression alterations without change in the DNA. And then another omics is microbiome. So all these omics, they provide great opportunity to advance science and medicine. But what I'm going to focus today is how they can exacerbate already existing health disparities. So for the rest of my presentation, I will focus on genomics. And one of the major milestones was the Human Genome Project. So this was an international research project to map all 20,000 plus genes and sequence all 3 billion base pair of the human DNA. It cost $3 billion. It was funded by the Department of Energy and the National Institute of Health. It lasted 13 years from 1990 to 2003. At the time, the technology allowed to read 92% of the genome, and they found that we have 22,300 protein-coding genes. Now, the Human Genome Project helped advance molecular medicine. It helps us identify disease-causing genes and mutations that might be linked to cancer. And it also helps establish gene sequence databases. From when the Human Genome Project ended in 2003 to today, the cost of genomic sequencing has gone down, right? So it went from costing 93 million to sequence somebody's genome. Now we can do that in for just a few hundreds dollars. The Human Genome Project lasted 13 years. Now we can sequence somebody's genome in less than 24 hours, right? And then it's also widely available. For example, right across my office, there's a laboratory here that does genomic and epigenomic sequencing. So widely available. Now I'm going to talk about a couple tools because this will help us understand some of the concepts I will discuss later. So the couple tools used in genomics are genome-wide association studies and polygenic risk scores. So genome-wide association studies, these are methods to allow us that can allow us to scan the full genome to identify genetic variants that are associated with a trait, or for example, a disease. Once we have identified those genetic variants, we can summarize them into what we call a polygenic risk score. Of course, accounting for how much each of the genetic variants can account for the disease, right? But here I would like to make a distinction between simple genetic traits versus complex genetic traits. In simple, we have one gene or one genetic variant that explain the trait. But for complex, we have a lot of genes or genetic variants that are contributing to the trait. Some application of genomics, the major one is personalized medicine. So some people don't like the use of the word personalized medicine. They prefer precision medicine, but I don't think it really matters here. But the National Human Genome Research Institute defined personalized medicine as a use of an individual genetic profile to guide decision in regard to prevention, diagnosis, and treatment of disease. Now, personalized medicine is a little broader than that. So it's not just the genetic profile. It's basically using biomarkers or the person characteristic to guide these decisions. But you understand that this definition is coming from the National Human Genome Research Institute. So they put a strong emphasis on genomics. And then the genetic profile can help select proper medication or therapy and administer it using proper dose regimen. So this is a good transition to talk about pharmacogenomics, or how someone's genetic makeup can predict drug efficacy or safety. In terms of efficacy, we know that, of course, drugs do work, but not all drugs work for everybody. In terms of safety, we know that 5 to 15% of hospital admissions are attributable to adverse drug reactions. And it is estimated that for half of the prescription drugs, we can identify genes that can determine the drug response or the adverse reaction. So we call these genes pharmacogenes. And the drug can be paired to a gene, and we talk about drug-gene pairs. And actually, the Food and Drug Administration has a list of 121 drug-gene pairs, and some of these are included in drug labels. So I talked about having complex genetic traits, and that's when I mentioned the polygenic risk scores. But in terms of pharmacogenomics, polygenic risk scores are still lagging behind because we have issues with power and sample size. But I also would like to be careful here and say that genetics does not account for all the variability. So the contribution of genetics varies from drug to drug, and it can also vary from patient to patient. So I mentioned drug-gene pairs. So the drug-gene pairs are actually being used in some medical centers. And here I have a webpage from the University of Colorado Medical Campus. They also have a webpage for personalized medicine. If you go on that page, you click on providers, you click on result, you click on pharmacogenomics, it will give you a list of medications. So for example, if I just click on antipsychotics, in situation, it will tell me the actionable gene associated with this drug. And then in recommendation, it will tell you that if you have a patient who is in the biobank and has had his genotyping done, if he has this actionable gene and you prescribe this drug, you will get a warning message. Same thing, for example, for statin, it will identify the actionable gene and also the recommendation. If the patient is in the biobank, also has the actionable gene, once you prescribe this drug, you will also get a warning message. So I talked about I talked about genomics, I talked about the tools, I talked about the application. Now I'm going to discuss the sources for disparities. So it has been reported that there is disparity in the quality and the quantity of genomic data. For example, if you look at the Cancer Genomic Atlas, so this is an atlas that involves 11,000 participants, and the racial and ethnic distribution follows that of the US, meaning if you have 13% of Black people in America, then 13% of those of the 11,000 are going to be, for example, Black people, right? So you can see on the left that I am reporting, the study actually is reporting whether we have enough sample or we have deficit samples to identify moderately frequent mutations. So the table is actually showing that to identify these moderately frequent mutations, white participants are at an excess of samples, and everybody else is at a deficit, except maybe for breast cancer among Black women. And on the right, I'm showing the difference in the quality of the genomic data. And the quality here is measured by number of reads per exome. So exome are part of the DNA that are actually being transcribed, right? And here it is showing that the number of read or the sequencing depth is different based on whether you have African ancestry or European ancestry. And they see those differences in the tumor tissues, and they also see them in peripheral blood. And basically you also see it for almost all the different types of cancers. Another source of disparity is the fact that the majority of the genome-wide association studies have been done in people of European ancestry. And you can see that people of European ancestry only represent a small part of the global population. And for everybody else, it's only a very small number of these GWAS studies that have been conducted. So I mentioned earlier polygenic risk scores, and we use the result of the GWAS to summarize this polygenic risk score. So the fact that most of the studies were done in people of European ancestry, it has a consequence in the predictive accuracy of this polygenic risk score. So here I am showing a graph of the predictive accuracy of a polygenic risk score. A polygenic risk score is developed using the UK Biobank for 17 traits. And you can see that the predictive accuracy among the European in whom this polygenic risk score were developed, the predictive accuracy is 100%. Now, if you use the same polygenic risk score and you look at how predictive it is in the American population, you fall below 75%. Same for South Asian, it's about 50% for East Asians. Now, if you apply this polygenic risk score among people in the African continent, it's basically useless. You are at about 25%. It even performs worse than a coin flip. Now I'm going to use the example of breast cancer screening to talk about how polygenic risk score can have an impact. So the United States Preventive Task Force Service recommend having mammography for women between the age of 40 to 74 years old once every 2 years. Now, if a woman has BRCA1 or 2 genes, the American College of Obstetricians and Gynecologists recommends starting screening much sooner at the age of 25 and doing it more regularly. And actually, they recommend having an annual MRI for women aged 25 to 29, and then starting at age 30, doing the MRI and mammography every year. So polygenic risk scores so far are not ready for the clinic, but they have been shown to be able to identify women who can be at high risk for breast cancer, especially if you combine them with family history, whether the person has BRCA1, BRCA2 genes, and other risk factors. And also know that there are clinical trials actually to look at the utility of this polygenic risk score. And one of the most promising polygenic risk score is the PRS 313, because it involved 313 genetic variants, and already it has been shown to have lower predictive accuracy in people who have African ancestry. There's also disparities in the use of pharmacogenomics. So for example, for the drug warfarin, so this is an anticoagulant to prevent blood clots, especially in people who have atrial fibrillation, but have the adverse effect of producing hemorrhages. And actually, there are some dosing algorithms that have been developed, but these are based on the different subtypes of CYP2C9 gene. And the subtypes used for this dosing algorithm are present in people who are of European ancestry, but not found in people who have African ancestry. There's also a disparity in drug labels, right? So for example, here's a drug used in multiple sclerosis. So I don't know much about multiple sclerosis and the different treatment options, but I'm guessing that they're quite limited. And one of the drugs used is siponimod. So this drug, if you look at the drug label, it instructs prescribers to genotype for CYP2C9 before prescribing the drug. And if the participant has the subtype 2-3, reduce the dose by 50%. And if the participant has the subtype 3-3, to avoid the drug. And like I said earlier, these subtypes 2 and 3 are only found in people who are of European ancestry. And unfortunately, the subtypes found in people of African ancestry, such as 5, 9, and 11, are not being studied. So here on the right, I have an example of this Mason drug. And if you look at the contraindication, it tells you not recommended for people with CYP2C9 3-3 genotype and people who have heart problems. And like I said, CYP2C9 3-3 is mainly found in people of European ancestry. Now, CYP2C9 is a very important gene because it is part of the cytochrome P450, meaning that it influences how drugs are metabolized. And unfortunately, some of the subtypes found in people of African ancestry are rarely studied. There's also the use of pharmacogenomics for drug safety. So I already mentioned the example of warfarin. I'm going to use another example, which is DPYD genotyping for the toxicity of fluoropyrimidine anti-cancer. So late in 2020, in Europe, they have implemented the genotyping. And unfortunately, they have developed this genotyping based on 4 variants identified people of European ancestry. And you can see here on the right, the table I'm showing. So this is, you can see the different recommended dose based on the gene activity score. But like I said, all this score is based on people of European ancestry. So I know you are already familiar with NIH All of Us. So I'm just going to give a very quick overview. So this is a program inviting 1 million participants. So far, we have 413,000 participants, 45% of which are from racial and ethnic minority groups, and 75% are from community groups who are represented in biomedical research. So the initiative was born from the personalized medicine initiative that President Obama talked about in his address of the Union in 2015. So I'm not going to go through the detail of the timeline, but just know that starting 2019, that's when the data was available to the researchers. So as I mentioned earlier, the majority of genomic studies were performed in people of European ancestry. So in NIH All of Us research, they oversampled the people from minority, racial, and ethnic and ethnic groups, and then they sampled people of European ancestry. So people come from all over the US. That's the map you see on the left. On the right, I have a distribution by racial and ethnicity among participants of All of Us. And at the bottom, you can see also the distribution by the different age groups. The type of data you can find in All of Us, you can find data from survey response, physical measurement, genomic data, data from electronic health records. Also, you have Fitbit records. And at the bottom, I'm showing here the different group of disease available in NIH All of Us. And you can see also, based on the color, whether the conditions affect mostly people who are from minority groups or non-minority groups. There is also genomic data, like I said, in All of Us. So it includes whole genome sequencing and microarray. So I gave a very simplified difference between the two. So the definition is that for whole genome sequencing, this determines the complete DNA sequence of the genome, while microarray allows to detect the predefined sequences. Whole genome sequencing is expensive, microarray is cheaper. Whole genome sequences generates a lot of data, therefore there is a need for storage and computing. That's not the case for microarray. So now I'm going to talk about two studies that have been done in all of us. So these are just examples on how they try to address the issue of this disparity. So the first study was done to look at the disparity in knowledge, in what we know from genetic variants that can cause diseases. So the study, in their background, they mentioned that disparity in data underlying clinical genomics interpretation is acknowledged. However, we don't have much data to show it. And in their result, they found that these pathogenic variants are more prevalent in people of European ancestry and significantly higher than in other racial and ethnic groups. And they conclude by saying that there is a bias in the ascertainment of the knowledge about these variants that can cause diseases. The second example of study using all of us is a study where they try to recalibrate polygenic risk score for 23 diseases. So I already showed you an example of how polygenic risk scores do not work for people of different ancestry groups. In this study, the investigators tried to recalibrate using people of different ancestry. The study has a few issues, so I'm not going to go into the detail of that for the sake of time. So I had a slide for that, but I'll touch on it on the next one. So I'd like to finish by talking about the challenges of including race and ancestry in genomics. So we know that race is often used as a proxy for genetic background and ancestry. It is a social, not a biological construct. Racial categories may not capture genetic diversity across groups given migration and the mixing of population. For example, you probably heard before, people say that you have more genetic diversity in the continent of Africa than in the rest of the world. Some people have suggested using ancestry-specific polygenic risk score, but there's a challenge there because you guys already know we have many diseases. And for every disease, if we were to have ancestry-specific polygenic risk score for every ancestry groups, that probably would not be practical. And then there would be the issue of people who have mixed ancestry. Another alternative was to have cross-ancestry polygenic risk score, like, for example, the study using NIH all of us tried to do. And then there, we also have another challenge, which is that we might have different distribution of this polygenic risk score. Basically, we might have define different cutoffs to identify high-risk groups. So for example, the cutoff for people of European ancestry would be different from the cutoff of people who have, for example, African ancestry. So in my last slide, I have information. If you need more information on NIH All of Us, I provided a link. If you are a researcher interested in registering and doing research in the workbench, I provided a link, and I also provided a QR code. If you are already registered in the NIH All of Us and would like to attend sessions to guide you on how to do the analysis, I also provided a calendar. So I'm going to leave this slide up, and then I'm available for any question you might have. Thank you.
Thank you so much, Dr. Mendy. We really appreciate that great presentation. Participants, you can find his contact information. And so for the sake of time today, we want to honor our schedule, but it was an amazing presentation. So please reach out directly to Dr. Mendy for any future questions. At this time, we will pass it forward to the chair of our symposium, Dr. Tam Nickerson. Thank you.
Thank you so much, Dr. Wright. I now have the distinct pleasure and privilege to introduce our keynote speaker, Dr. Leandris LaBird. Dr. LaBird is an acting director for the CDC's Office of Health Equity. She has served as the Associate Director for Minority Health and Health Equity for CDC ATS-DR since 2011. In this capacity, she leads and supports a wide range of critical functions in the agency's work in health equity, women's health, and diversity, equity, inclusion, and accessibility. She plays a critical leadership role in determining the agency's vision for health equity, ensuring a rigorous and evidence-based approach to the practice of health equity, and promoting the ethical practice of public health in communities vulnerable to health inequities. Dr. LaBird has been instrumental in building capacity across the CDC and public health agencies to address the social determinants of health and in identifying and widely disseminating intervention strategies that reduce racial and ethnic health disparities. In May 2020, she assumed the role of Chief Health Equity Officer for the CDC's COVID-19 response, which was the first time in the agency's history that this role and function was added to the leadership of the incident management structure during the activation of the CDC's Emergency Operations Center. These and other accomplishments represents her tireless commitment to improve minority health and achieve health equity for all people. Dr. LaBerge holds a Bachelor of Arts degree from the University of Michigan at Ann Arbor, a Master's of Public Health in Education from the University of North Carolina at Chapel Hill, a Master's of Arts in Cultural Anthropology, and a Doctor of Philosophy degree in Medical Anthropology from Emory University. Please give a warm welcome to our keynote speaker, Dr. Leandris LaBerge.
Thank you so much, Ms. Nickerson, and good afternoon. And thank you to everyone for the invitation to be part of this important research symposium and for the opportunity to share our work among such distinguished researchers. I also want to congratulate Delta Sigma Theta Sorority Incorporated and DREF for your participation in the All of Us initiative and your recognized leadership in advancing health equity. I cannot think of a greater service you could provide to our community. This afternoon, I will share our definitions of public health concepts, and we come from a public health perspective, and briefly explore some of the causes of health inequities. I'll then share CDC's current approach to pursuing health equity. And finally, we'll look specifically at a critical health equity issue, which is Black maternal mortality, and some of the ways in which CDC is addressing it. So we define health equity as the state in which everyone has a fair and just opportunity to attain their highest level of health. It is important to recognize that not all individuals will be able to attain their highest level of health on the basis of their actions alone. So achieving health equity then requires focused and ongoing societal efforts to address both historical and contemporary injustices. We must also overcome economic, social, and other obstacles to health and healthcare, and to ultimately eliminate largely preventable health disparities. Health equality, another term, is when each person or group of people is given the same resources or opportunities. And then we consider health inequities, which are particular types of health disparities that stem from unfair and unjust systems, policies, and practices that limit access to the opportunities and resources needed to live the healthiest life possible. Differences in access to health insurance coverage is a good example of a health inequity, as this can impact a person's ability to get health care. It can impact the quality of that health care and ultimately their health outcomes. So a health disparity is a plausibly avoidable, systematic health difference that adversely affects a socially or economically disadvantaged group. I want you to note that this definition does not require establishing that the health difference was caused by social or economic disadvantage. It requires only observing worse health in a socially or economically disadvantaged group. Moving on to social determinants of health, These are, as we've heard earlier today, the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of their daily life. So let's look at a few current inequities and some of their causes. So looking at a snapshot of selected health disparities by race and ethnicity in the US, we see several disparities across population groups. Black people faced increased risk of disease and negative health outcomes, including increased risk of heart disease, diabetes, and one we will talk about in more depth later in this presentation, maternal mortality. American Indian and Alaska Native persons and Hispanic persons also face increased risk of certain conditions. And this is just a small snapshot of a vast number of differences in health outcomes across population groups. But rather than just stating that these disparities exist, we need to explore and address their causes. So we often discuss health using the metaphor of a stream, with upstream factors bringing downstream effects. So what do we mean by moving upstream? Public health, among other agencies and groups, can work to create health equity at 3 levels. The downstream, immediate health needs of populations that are marginalized. The midstream, intermediary determinants or material circumstances such as housing conditions, employment, and food security. And the upstream, structural determinants such as social status, income, systemic racism, and exclusion. This is often depicted in a classic public health parable credited to medical sociologist Irving Zola. And this is the parable. A witness sees a man caught in a river current. The witness saves the man, only to be drawn to the rescue of more drowning people. And after many have been rescued, the witness walks upstream to investigate why so many people have fallen into the river. The story illustrates the tension between public health's protection mandates to respond to emergencies, that is, to help people caught in the current, and its prevention and promotion mandates to stop people from falling into the river. Improvements in our nation's health can be achieved only when we have the commitment to move even further upstream to change the community conditions that actually make people sick. So upstream factors such as structural, systemic, and institutional inequities contribute to the personal, social determinants of health status, such as food security, housing security, poverty levels, and other social factors that affect health outcomes. So the last 3 decades of working to reduce and eliminate health disparities has taught us that we can be effective through our science and programs, by training our workforce, and using effective approaches to communicate about health equity and related concepts. And of course, with partnerships, because we cannot do this work alone. So keeping all of this in mind, I'd like to share some of the ways that CDC approaches health equity. So first of all, as a result of a recent reorganization, CDC established the Office of Health Equity, building upon more than 30 years of our commitment to reducing particularly racial and ethnic health disparities. The Office of Health Equity exists to ensure that health equity is embedded in an all of public health approach to overcoming persistent health disparities and health inequities across a range of population groups that disproportionately experience poor health outcomes. Our vision is that all people have the opportunity to attain the highest level of health possible. In 2021, CDC launched CORE, which is our first agency-wide health equity science and intervention strategy. CORE strives to move beyond naming differences through markers, and we consider markers things such as race, to identifying and addressing changeable drivers of health inequities, such as housing, neighborhood conditions, and access to healthcare. So CDC's core commitment to health equity stands on 4 key pillars that you see here. The C stands for cultivate comprehensive health equity science. And I'm really excited that we've actually published our health equity science principles. The O is for optimized interventions. The R is for reinforce and expand robust partnerships. As I said before, we cannot achieve health equity through the efforts of public health and medicine alone. And then E is to enhance capacity and workplace, as well as workforce diversity, inclusion, and employee engagement. So since 2021, when we first launched CORE, across the agency, over 150 catalytic goals have been submitted that fit into 7 overarching health equity themes that you see here. Another example of just one of the Office of Health Equity's initiatives, and this is one we're particularly proud of, is the CDC John R. Lewis Undergraduate Public Health Scholars Program and the Dr. James A. Ferguson Emerging Infectious Diseases Graduate Fellowship. These programs, this year we will celebrate the 35th anniversary of the Ferguson Fellowship. And these programs provide opportunities for both undergraduate students and recent graduates to gain meaningful experiences in public health. For over 30 years, our office has collaborated with educational and health institutions to increase the knowledge, the diversity, and the skills of students and recent graduates in public health through these internship and fellowship programs. And we know that these programs are effective. An evaluation of our John R. Lewis program showed over 75% of participants stayed in the public health field for their careers, and 90% said the program helped support their career choice. So these programs play a critical role in advancing health equity. So now that I've laid some of the foundation for how we think about health equity, health inequities, as well as CDC's approach to health equity, I want to now take a closer look at a pressing and unacceptable health inequity in the United States, which is Black maternal mortality. So each year in the United States, too many people die during pregnancy or in the year after. Thousands more have unexpected outcomes of labor and delivery with serious short or long-term health consequences. Pregnancy death is defined as the death of a woman during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication. A chain of events initiated by pregnancy or the aggravation of an unrelated condition by the physiologic effects of pregnancy. Every pregnancy-related death is tragic, especially because 4 out of 5 pregnancy-related deaths in the United States are preventable, and more than half of those occur postpartum, up to 1 year after delivery. So, what are the causes of maternal mortality or pregnancy death? So, using data from maternal mortality review committees, and I think we have another slide. Yes. So using data from maternal mortality review committees, which are multidisciplinary committees that convene at the state or local levels to comprehensively review deaths during or within a year of pregnancy. Data from these committees reveal that mental health conditions, hemorrhage, which you know is excessive bleeding, cardiac and coronary conditions, infection, thrombotic embolism, and cardiomyopathy accounted for over 75% of pregnancy-related deaths. Mental health conditions include deaths due to suicide, unintentional or unknown intent of overdose or poisoning related to substance use disorder, and other deaths determined by the MMRC to be related to a mental health condition, including substance use disorder. It's important to note that the leading causes vary by race and ethnicity. For instance, mental health conditions are the leading cause of death for Hispanic people and non-Hispanic white people. And cardiac and coronary conditions and cardiomyopathy are the leading cause of death for non-Hispanic Black people. So considerable, racial and ethnic disparities in pregnancy-related mortality exists, clearly. Non-Hispanic, Native Hawaiian, and other Pacific Islanders, Black, American Indian, and Alaska Native people have the highest rates of pregnancy-related deaths. 2019 was the first year that CDC released information for Native Hawaiian and other Pacific Islander persons as a separate race category to improve the documentation of the disparities that need to be addressed. The pregnancy-related mortality ratio, as you can see, is also higher in rural than when compared to urban areas. So multiple factors contribute to these disparities. There's variation in the quality of healthcare and other social determinants of health. Social determinants of health prevent many people from racial and ethnic minority groups from having fair opportunities for economic, physical, and emotional health. And we heard about that from Mrs. Johnson earlier. As well as underlying chronic conditions and structural racism and implicit bias. In a 2022 study, the MMRCs determined whether discrimination contributed to the pregnancy-related death, and not just whether the individual was exposed to discrimination. So discrimination in this instance is defined as treating someone less or more favorably based on the group, class, or category they belong to, resulting from biases, prejudices, and stereotyping. And this can manifest as differences in care, in clinical communication, as well as in shared decision-making. And again, we heard about this earlier. So the committees determined that discrimination is a circumstance that contributed to 30% of deaths. Just taking a closer look at Black maternal mortality. Non-Hispanic Black women are 3 times more likely to die from a pregnancy-related cause than non-Hispanic white women. Why? Well, some of the contributing factors to maternal mortality disparities and how they may play a role in Black maternal health include, as we've discussed before, structural racism and implicit bias can have damaging effects on maternal health. For example, delaying the start of prenatal care is actually associated with personal experiences of bias and racism. Structural racism has impacted the distribution of social determinants of health, such as economic and educational opportunities, which in turn create less opportunities to achieve optimal health, which we also heard some about earlier. But however, and this is also very important to know, even at higher levels of education, there are disparities in maternal mortality. Black women with a college degree are more likely to die from a pregnancy-related death than a white woman with less than a high school diploma. The weathering hypothesis that I'm sure you've heard of posits that Black women experience earlier deterioration of health because of the cumulative impact of exposure to psychosocial, economic, and environmental stresses. A 2023 Vital Signs report, which is a report that CDC puts out throughout the year on different topics, found that 1 in 3 women report mistreatment during pregnancy or delivery. And Black women and women without health insurance are most likely to report mistreatment. So we have an unprecedented opportunity to accelerate progress in shifting patterns of maternal health disparities in our country and those that are avoidable. CDC has identified 4 focus areas where we are bringing timely data, evidence, and best practices to address challenging health threats with our partners. For example, preparedness, young families, which I'll say a little bit more about, mental health, and also moving forward. We have an initiative called CDC Moving Forward. It's One CDC. And one of those is breaking down silos so that we can support and better support young families. And within this focus, CDC is prioritizing upstream prevention so that children and their families have what they need to thrive no matter where they live. One of the collaborative initiatives within this focus area is improving care for pregnant and postpartum mothers. There are 2 collaborative efforts that CDC is partnering in alignment with the White House blueprint for addressing the maternal health crisis. And they are hypertensive disorders of pregnancy. And in that, we are leveraging the recent extension of Medicaid postpartum coverage in most states. CDC is supporting blood pressure self-monitoring and implementing the hypertension and pregnancy quality improvement change package, and then leveraging the recent extension of Medicaid postpartum coverage in most states. So that being leveraged to a year postpartum. CDC and CMS will accelerate maternal care quality improvement efforts at hospitals through collaboration between CDC's perinatal quality collaboratives and CMS's birthing friendly designation initiatives. We are also supporting states through the enhancing reviews and surveillance to eliminate maternal mortality, or the ERASE program. This work facilitates an understanding of the drivers of maternal mortality and complications of pregnancy to better prevent maternal deaths and reduce racial disparities. We are also supporting the state perinatal quality collaboratives to improve the quality of care for mothers and their babies. And we are also helping states to standardize their assessments of levels of maternal and newborn care for their delivery hospitals by offering the CDC levels of care assessment tool, as well as providing technical assistance to those who want to use it. And lastly, but certainly not least, we're promoting the Hear Her campaign to raise awareness of potentially life-threatening warning signs during and after pregnancy, and improving communication between patients and their healthcare providers. We know how essential that is. So in closing, there are many ways that you can connect with us in our Office of Health Equity, and then by extension across CDC, where much of this work is coming from. And you can also email us. You can scan using these QR codes to access a variety of our resources. So thank you again for this opportunity to speak with you about health equity and CDC. And thank you again on behalf of certainly my community for all of the work that you're doing and the leadership that you're providing.
Thank you so much, Dr. Libbard. We had a few questions, but your presentation was so phenomenal. You addressed almost all of our questions beautifully. So we are so grateful for your time today and you being here with us and providing such an insightful communication. So at this time, we'll move forward with the few minutes we have left designated for the day. And we do have one evaluation, I do believe. If there's technology can help us, it's in the chat. So attendees and or on the slides of attendees, we'd be so grateful for your feedback that again helps us guide programs and public communications like this. Thank you all so much for attending and have a wonderful afternoon. We do have some closing remarks, so I'll pass it along to my colleagues. Thank you again. And one other additional note, please forgive me, just a reminder that this session, this symposium, you can earn educational, continuing educational credits, medical credits. And so there are some directives on how you can obtain those credits either through the QR codes provided or in the links provided. And there's two parts to that. So please make sure you complete both parts of the assessment so that you can get full credit for your attendance here today. Thank you so much.
Thank you so much, Dr. Wright. As we close out on today's symposium, I would like to extend a very special thank you and acknowledgement to our National Research Symposium subcommittee members who are listed here on your screen for their assistance in planning and organizing our event today. You are greatly appreciated. We would also like to extend a special note of gratitude to our keynote speaker, Dr. Leandris Labird, our workbench demonstration presenter, Dr. Angelico, Mindy, and our fireside chat contributor, Mrs. Karen Walker Johnson, for lending your expertise in the health equity and its effects on our communities. We will certainly leverage this information that we learned today and implement it in our professional and personal lives. Lastly, we would like to give our principal investigator, Cheryl Thomas, and our program manager for DREF Research Matters for All of Us, Dr. Kay Williams, an opportunity to provide final remarks in the closing. Thank you again.
Good afternoon. I am Dr. Kay Williams Dawson, the program manager for the DREF Research Matters for All of Us initiative. And on behalf of Renee Harper, President, DREF Board of Directors, Carla Green, DREF Executive Director, Cheryl Thomas, Principal Investigator, DREF Research Matters for All of Us Initiative, and the entire Research Matters team. I want to thank all of you for joining us in this critical and most important research webinar, hosted by Dr. Mandy Hill, DREF's researcher specialist, and the amazing 22 DREF researchers that make up the research working group. Today, we have brought our folding chairs and created a seat at the table to ensure that we help to shape the health equity narrative. Thank you for a well-spent couple of hours to engage and be informed about health equity in our community. Now, please welcome and hear final remarks and special acknowledgments from DREF's Principal Investigator, Cheryl Thomas.
Good afternoon and greetings. Thank you for joining us for such an amazing afternoon and a very informative conversation focused on health equity and the work that's being done with in that area, as well as with the DREF 22 researchers. I'd like to provide a special thanks to Dr. Kareem Watson, who is the Chief Engagement Officer for the All of Us program. Dr. Watson has been our champion throughout these last several years. His guidance and his leadership is just amazing, and we appreciate his support and the work that and his remarks today. Also, Dr. LaBird, it was wonderful hearing about the work that's being done at the CDC relative to your health equity initiative. The maternal health example is very real in our community. And thank you again for all of the information that you shared with us. Dr. Johnson, Walker Johnson, thank you as well for providing your perspective of the challenges that we face as a community relative to health equity. And Dr. Mindy, as well as Dr. Cousins, it was great to see your presentation and listen as to how you have utilized the All of Us data set to transform data into real information that can help us. I would be remiss if I didn't provide a special thanks to the DREF 22 members and a special shout out to the leaders of the cohort 2 committees. And they include Dr. Leanne Harris-Wright, Dr. Denise Kimbrough, Ms. Tamara Dickerson, Dr. Lena Ellis, Dr. Nashika Jackson Ogilvie, Dr. Lakeisha Cousins, Dr. Kalisha Mays, Dr. Monique Papadis, Dr. Malika Hall, and Dr. Heather Rice. We appreciate your leadership and all the work that your committee members have done this year. And lastly, but not least, I'd like to just express my appreciation for Dr. Mandy Hill. She has done a tremendous job in leading this initiative. She's juggled many priorities in her life, but she's always made us feel that we are number one. And You can see from the quality and the expertise that was provided today, the work that she's done. So thank you very much, and thank you all for joining us. And now I'll turn it back over to the team.
Wake up. You've got the power. You've got my people in the east, yo, you gotta wake up. Midwest, dirty South, yo, you gotta stand up. All my homies in the west, yo, you gotta wake up. Wake up, wake up, wake up, wake up. Wake up, wake up, wake up, wake up. Wake up, wake up. Wake up, everybody, no more sleeping in bed. No more backward thinking, time for thinking ahead. The world has changed so very much from what it used to be. There's so much hatred, war and poverty. Wake up, all teachers, time to teach a new way. Maybe then they'll listen to what you have to say. 'Cause they're the ones who's coming up. The world is in their hands. When you teach the children, teach them the best you can. Bring peace, do we mean it? Can you feel it when we scream it out loud? Do you believe that we need it? Do you believe that it could get right? Do you believe that the children of the world deserve a good life? Well, if you do, it's time to wake up your mind. We can make it better, and I know it might take some time, but we gotta start somewhere. How about with you and me? From us it goes to others, then we'll have our unity. All the doctors make the old people well. They're the ones who suffer, who catch all the hell. But they don't have so very long before the judgment day. So won't you make them happy before they pass away? Wake up, all the builders, time to build a new land. I know we can do it, long as we lend a hand. The only thing we have to do is put it in our minds, and surely things will work out, 'cause they do it all the time. I ain't here to take up y'all time. I came to shake up y'all mind. It's everybody's wake up call time. I can't sleep too long. Why they do the people wrong? Let's clean the world up before they sweep you gone. This is real talk. You can peep through songs. So when you feel weak, these words will keep you strong and help make a change for the better. It's hard for one to do it, but we can make some changes together. Ghetto. To the man upstairs, put the egos and the pride to the side regardless, and just be role models, parents, artists. We can make a change and we can make it the hardest. If you gonna make a baby, you should make them the smartest. Let them know good and bad, right from wrong, how to roll with the punches when life moves on. And the stress won't take toll if you don't sweat it. World won't get no better if we don't let it. Let the negative energy ride, keep hope alive. It's about time that we open our eyes. Wake up, everybody, no more sleeping. Time for the second guess. The words I speak. Wake up.